Good afternoon. I'm Tonya Winders, the President and CEO of Allergy and Asthma Network. And today we're going to look at asthma, allergies, and the long-term effects of the COVID-19 virus. Certainly the COVID-19 pandemic seems to be hanging on longer than any of us expected, and its impact continues to be far-reaching. At Allergy and Asthma Network, our mission is to end the needless death and suffering due to asthma, allergies, and related conditions through our 4 mission areas: outreach, education, advocacy, and research. This webinar marks the 30th in our COVID-19 webinar series. We began these webinars in March of 2020 as a way to bring you the latest scientific and practical information about COVID-19. We wanted to provide the information that relates to you and will continue to do so until the pandemic has passed. So again, welcome for today, the latest impact of COVID-19. Today we welcome back Dr. Vickram Tejwani. Dr. Tejwani is an assistant professor at the Cleveland Clinic Lerner College of Medicine, where he joined this year as a staff physician in the Asthma and COPD centers after completion of a pulmonary and critical care fellowship at Johns Hopkins University. Beyond Dr. Tejwani's clinical role in asthma and COPD, he is an active scientific investigator in both diseases and has served in the COVID intensive care unit over the last 18 months. He is passionate about patient education and has enjoyed partnering with Allergy and Asthma Network on numerous patient-centered and academic endeavors. Welcome, Dr. Tejwani, and thank you for being with us.
Thank you.
In the balance of our time together today, here is the program outline. First, we will take a look at the current state of COVID, and then we will provide an update on vaccination and variants. Then we'll turn the focus to allergies and asthma in relation to COVID-19. And then finally wrap up our time around long-haul consequences of COVID-19. Again, we encourage you to submit your questions, and we'll get to as many of those as possible at the end of our webinar in our Q&A time. So we always like to get you, the audience, involved. We're going to launch our very first poll and see who is with us today. So which category best describes you? Physician, PA, nurse practitioner, nurse, school nurse, respiratory therapist, asthma educator, or patient. Choose the one that best describes you. We're super excited that even at our 30th webinar, we have over 900 people registered for today's webinar. And we hope that, again, we'll have a multidisciplinary audience like we typically do for this topic. We'll give it just another moment, and then I'll share the results. Great. So looks like that we've got 5% physicians, 4% PA nurse practitioner, 60% nurse, school nurse, 24% respiratory therapist, asthma educators, and 7% patients. Right? Oops, so sorry, didn't mean to do that. All right, so now let's take a look at the current state of COVID-19. As we always do, we will take a look first at the Johns Hopkins COVID-19 dashboard for the current statistics on total cases, the death toll, and total vaccine doses administered. And so again, what you can see here is that we've had 222, almost 223 million cases across the world, with 4.6 million deaths, quickly approaching that number of 4.6 million deaths due to COVID. And then we do have our vaccination rates that are continuing to go up. And again, the wealth of information that's available here at the Johns Hopkins COVID-19 dashboard, where you can actually dive into the US data over the last 28 days. You can look at other countries in comparison. And again, we can see those trend lines. We have begun to see yet another little decline here in the last few weeks and days. And so hopefully, again, as we look at the other sources of data, we'll see that as well. Now at the CDC, the way that the data is presented, remember it's a bit of a lag from the Johns Hopkins data, but the darker the state, the higher the 7-day case rate per 100,000 population. So again, we see that clustering that we have noticed before in the southeastern United States, but we also have some higher rates, case rates in Alaska, and also in Kentucky and West Virginia. So a lot of areas there that, again, have not previously been that darker blue that currently are. Here in the US, again, over 40 million cases total, and total death toll of close to 650,000. Now, what about the headlines? When we turn on the news, the things we're hearing about this week and last week, that FDA has approved the first COVID-19 vaccine fully. So not only the emergency use authorization, but now the full approval of the Pfizer BioNTech COVID-19 vaccine. And we'll talk a bit more about this when we get to our vaccine section of the webinar today. Unfortunately, we are seeing a rise of child COVID cases and hospitalizations. And we believe that this is a result, especially in the Southeast, of schools reopening in August and more lax provisions of mask wearing and infection control measures. So when we think about protecting unvaccinated children, Dr. Anthony Fauci from the NIH has a wonderful quote here. The way you protect children who, because of their age, cannot get vaccinated yet is to surround the children, whether it be their friends, family, teachers, or school personnel. Surround the children with vaccinated people. So we as adults have the responsibility to create a safe community and environment for our children to learn. Dr. Fauci has also reported that the US will likely start to widely distribute the Pfizer COVID-19 booster shots in the 3rd week of September. And so again, those that got the vaccination early will be able to get their booster shots beginning later this month. And the rollout of Moderna's vaccine could be delayed. The company is actually waiting on regulatory sign-off for the 3rd dose. And so until that time, it's likely that that will be delayed. The US has announced plans to give additional Pfizer and Moderna shots 8 months after your 2nd dose of the vaccine. And that has sparked some criticism as many countries actually struggle to get their populations vaccinated. So while we as a nation begin to move forward into the booster, still globally, many have been unvaccinated, and it has created some bit of a buzz around international relationships. President Biden is actually scheduled to give a speech today at 5 p.m. Eastern outlining a 6-pronged COVID plan, and he plans to include vaccine and mask mandates in that 6-pronged plan, according to our sources. Now, again, the country's highest office of a physician, our Surgeon General, Dr. Vivek Murthy, says that misinformation on social networks continues to damage America's health. It's the speed, scale, and sophistication with which COVID-19 is spreading and impacting our health that really continues to be unprecedented. And it's happening largely, Dr. Murthy says, in part aided and abetted by social media platforms. And again, at the network, we try to work with social influencers and leverage the social platforms for the good to promote the science and the evidence-based approaches. However, from time to time, we still are made aware of less than credible sources that people are getting their information from. And I think that's clearly what the Surgeon General is reinforcing here. Now, when we look at the new cases by day and the trend line from CDC, again, as I was suggesting earlier, what we've seen in the last week to 2 weeks is that slight decline. So we saw this second surge, albeit nowhere near the original surge back in October, November of 2020. What we're seeing here in that July, August timeframe was beginning that uptick. But now, since August, the week of August 23rd, we're beginning to see a slight decline and reaching those levels of under 100,000 new cases per day. Again, largely due to the variants, which we'll speak about in a moment. So now let's go to our second poll question. Do you think that you will get a COVID-19 booster when it becomes available? Go ahead and log in your results. Yes, no, not sure, or need more information. Give it just a moment, get everyone's response logged, and then share across the community. Right, thank you all for participating. Let's share the results. Looks like 72% say yes, that they will get the booster, 7% say no, 13% still unsure, and 8% suggesting that they need more information. And this is very understandable. Again, there is not long-term data on the use of the COVID booster vaccine. And so we certainly understand some of the concerns and the need for additional information. So let's continue on. And at this point, I'm going to turn it over to Dr. Tejwani for the vaccination and variant update. Dr. Tejwani?
Yes, thank you, Tonya, and thank you to Allergy and Asthma Network for hosting this and all those attending as well. Glad and certainly sobering to be here talking about this topic, particularly I think, given many of us thought, certainly myself included, we might be in a different state heading into the winter this year. On the next slide, you could see some of the national vaccination data, and it's starting to get a little bit more encouraging as far as the numbers of those within the country that are fully vaccinated. We're up to 177 million. And those that at least received at least one dose, and this is still important, is 208 million. At least in the pre-Delta era, we know that a single dose of the Pfizer Moderna would still confer about an 80% protection against being hospitalized or severe illness compared to the 95% with both doses. That, of course, those numbers will look a little bit different now with higher transmission and a more infectious strain circulating. Importantly, as Tyne mentioned in her introduction, a lot of these numbers, particularly in the context of the approval for this vaccination for those only over 12 years of age, really are focused on the adult and adolescent population. So the fourth line in this, I think, highlights an important number, which is that still, when you include the children, the childhood population in this country, we're still left with 30%, actually up to 40%, 38% that haven't been fully vaccinated yet. What that all kind of bears down to is a lot of vulnerable people walking around, really of all ages, and particularly with things reopening as summer is ending, we're seeing some of the consequences of that, unfortunately. Encouragingly, I would say on this slide, we are seeing those that are older individuals, and many of these individuals I know from my own patients were kind of first in line earlier this year to get vaccinated, and that is encouraging because they are the most still the most vulnerable to some of the very severe consequences of this virus. In the next slide, we see that much like kind of the mini outbreaks that occurred in 2020 before the vaccine was released, a lot varies based on where you are. There's, of course, state by state, region, and honestly, even within states, there can be city by city variation, which is relevant. So here you're seeing the percentage of the state population vaccinated with the darker colors, indicating a higher percentage of that population vaccinated. And you see the lighter colors track pretty well, actually, with what Tonya showed earlier, as far as where the highest current circulation rates are. We're seeing Wyoming, the Southeast, of course, being very heavily hit. It's encouraging now to see Florida a little bit darker. I think one of the silver linings of the Delta variant and kind of the fourth or fifth spike, depending on how you characterize it, is that it's really prompted a lot of people that were potentially a little bit hesitant about getting the vaccine before to go ahead and receive it. And you're seeing in the Northeast and over on the West Coast that there's a little bit less transmission there, given a more vaccinated population. Some of that, particularly in New York, has to do with legislation and different rules around entering restaurants and things of that nature. Another way to look at this is vaccination by age group, which is shown on the next slide. And as I think this, to me, interpreting this kind of tracks along with what you would generally expect, which is that the older population has a higher desire to get vaccinated. And I think that's based on a lot of what we learned early about this disease before the vaccine, which was that, generally speaking, older individuals did experience more severe acute illness, meaning they're more likely to be in the intensive care unit, more likely to be ventilated. We'll talk about some of the other consequences, the long haul version of COVID, because I think understandably what's reported, because it is the most important, is death and intensive care, requiring intensive care and a mechanical ventilator. But there are a number of other consequences that are not as age specific that can have lasting consequences and aren't captured as well. But here, anyway, we are seeing that older individuals, likely due to a perceived and real higher risk of more severe illness, are more likely to be vaccinated. In the next slide, we're seeing that, as Tonya mentioned as well, that the Food and Drug Administration, I think this was great for legislative and regulation purposes, approved the first COVID-19 vaccine. They approved the Pfizer vaccine, and of course it'll be marketed under a brand name. And despite the EUA or emergency use authorization for those 12 and older, so far they've approved it for those that are 16 and older. And again, for those 12, 13, 14, and 15 years of age, it remains available under an emergency use. And at this point, officially, a third dose in immunocompromised individuals with a pretty narrow definition currently is available as a booster. Going to the next slide, we hear a quote from Dr. Woodcock, who's the acting director or commissioner of the FDA. And essentially what she's saying is that the approval of this vaccine is a milestone as we're continuing to deal with this pandemic. This and the other vaccines, I would say, including the Moderna, which is the one I received myself, have met the FDA's rigorous scientific standards for emergency use authorization. And now the Pfizer one specifically has received FDA approval. The public can be very confident that this vaccine meets the high standards for safety, effectiveness, and manufacturing quality that the FDA would require of an improved product. While millions of people have already safely received these vaccines, we recognize that for some individuals, the FDA approval may now instill additional confidence to get vaccinated. Today's milestone, this was a couple weeks ago now, puts us one step closer to altering the course of this pandemic. And I think where the implications are, my personal view is that probably people that were interested and thought of were safe before this may or may not have changed much. I think there's a very small percentage of the population that maybe was on the fence, and with this FDA approval, it maybe potentially changed their mind. I think what it does open the door for is employers, organizations to potentially have a little bit more of a leg to stand on, because they're not potentially requiring something that's under emergency use. And just for context, I know many of the attendees are in the medical field, so this won't come as a surprise to them, but in the intensive care unit, in the clinic, in outpatient practice, we use many things that make sense and actually don't even have FDA approval. Pretty much any therapeutic that you've heard of for COVID, monoclonal antibodies, remdesivir, plasma, none of those at this point have FDA approval. So this is definitely a high standard to meet, and I think should certainly be reassuring and encouraging. On the next slide, I think other than vaccines, what is probably the biggest concern for most is the variants and the potential for mutation of the spike protein and other aspects of the coronavirus. So the predominant variant at the moment in America and was predominant in the UK a couple months ago is the Delta variant. I actually remember in June, we did a webinar when this was just starting to come here. And at the time, the data on it hasn't changed much, which is somewhat good. It's very highly infectious, so it's much stickier than the Alpha variant, which is the initial variant of the coronavirus. As far as we know, so far, it's really not clear if it actually causes more severe illness at all, but it's definitely more transmissible. And one thing that I think has made it even more transmissible is, unlike the Alpha variant, when you look at the amount of this virus in individuals that have been vaccinated, they can still carry it at a higher viral load than they would previously. So I think compared to the Alpha variant, whereas vaccinated people would not get sick and really not carry or transmit that much, I think with the Delta variant, there's still a potential that individuals that are vaccinated, although they may not be the ones or are not really the ones ending up very sick in the intensive care unit or in the hospital, still have the potential to unfortunately transmit the illness. And that has a lot of implications for school openings, social gatherings, etc. There remain other variants of interest, such as the Lambda variant. This has been much more prevalent in South America. It has been documented, it's predominant there. There's not a whole lot of data on it. So far, encouragingly, there are two things I would say that are reassuring about it. One is it's clear that it's not as infectious as the Delta variant, for better or worse. So the Delta variant, at least for the foreseeable future, is really going to be the predominant variant we're dealing with. There was concern with some of the vaccines in South America that it was not as responsive to those, but there was just a study released late last month where with the Pfizer and Moderna vaccine, it actually is effective. And that's really true for Delta as well. And that's honestly been a little bit of a saving grace through all of this, that despite these mutations that are affecting transmissibility, potentially causing more severe disease, although that's not clear, the vaccines have still proven to be really remarkably protective against severe disease. On the next slide, what this kind of illustrates is that this virus is mutating, which isn't surprising, unfortunately, and there are a number of strains that are being monitored. As far as transmissibility, none of them really seem to compare to the Delta variant, and the reason that we can say that is they tend to peak fairly early wherever they develop. Again, the Lambda and Mu as well, both being in South America, other ones having originated in India, and Delta either in India or the United Kingdom. None of them that we've seen so far have been also very have been unresponsive to the vaccine. The Mu variant might be, but again, if it doesn't have that combination of high transmissibility and vaccine resistant, we're on relatively okay footing. But if there is a strain that develops that is both highly transmissible, like the Delta variant, and then maybe has the vaccine resistance of the Mu or another variant that we haven't identified yet, then it really honestly kind of resets this whole situation. And so I think that's really what we're hoping. And really it is just hoping. Unfortunately, there are some ways to avoid that, which is really pretty widespread vaccination to avoid spread in the virus, a ground to mutate. But if it does happen, it'll be a major setback. Anyway, so on that sobering note, Tonya, we'll pass it back on to you.
Thank you, Dr. Tejwani. And it is sobering. I think all of us would agree that, we have pandemic fatigue, go to meeting, go to webinar, Zoom, Teams fatigue. I mean, we all want to resume life in whatever quote unquote normal fashion pre-pandemic. And yet the truth is that COVID-19 continues to significantly impact our community. And so that's why in our next section, we're going to talk a bit more about asthma and allergies and the impact of COVID-19. So one of the questions that has come to us routinely are people with asthma at increased risk for COVID-19. And according to the American College of Allergy, Asthma, and Immunology, asthma patients are generally at higher risk for respiratory infections and for complications or more severe infections. The COVID positivity rate in the asthma community, according to a recent study, was 69.2% in people with asthma, compared to 81.9% of people living without asthma, the non-asthmatic population. So we do see that the severity of disease is similar. Sometimes it's really hard to understand what's going on because the COVID-19 symptoms absolutely can mimic asthma symptoms with shortness of breath, cough, and wheeze. But what we do know is that the controlled state of asthma absolutely has greater impact and influence on the complications due to COVID. So if you have controlled asthma before you contract COVID, you have much better outcome than if you have uncontrolled asthma prior to contracting COVID. Do people with asthma and high eosinophils have a COVID-19 advantage? And so again, eosinophils are the cytokine that actually is in the inflammatory process of many of those living with asthma. It is often called type 2 inflammation or eosinophilic asthma. And 53% of asthmatic COVID-19 patients previously had elevated absolute eosinophil counts. This group had a significantly lower likelihood of hospital admission, according to the study. And the pre-existing eosinophilia may have had a protective effect against hospitalization for COVID. So that asthmatic COVID-19 patient who develops eosinophilia while in the hospital could have a lower mortality rate. And again, this is a study that was recently published in the Allergy journal. Now, what about allergies and COVID-19? Again, a common question that we've received: what should people do if they have an allergic reaction to the COVID-19 vaccine? Again, we have seen very rare cases of allergic reactions to the vaccine. And so the recommendation here is that if you have a severe allergic reaction or an immediate allergic reaction, even if it wasn't severe, to any of the COVID-19 vaccines, that you should not get either of the currently available vaccines, so the Pfizer and Moderna, the mRNA vaccines. If you've had a severe allergic reaction or immediate allergic reaction to any ingredient in the Johnson & Johnson-Janssen COVID-19 vaccine, you should not get that particular vaccine. Now, if you aren't able to get one type of COVID-19 vaccine because of that allergy to an ingredient, you should discuss with your doctor if there is a type that would be safe for you. So this is a conversation and a shared decision-making process that we would highly encourage patients to have with their individual physician. The next question: how can people tell the difference between COVID-19 and seasonal allergies? And again, here we have a response from the Cleveland Clinic where Dr. Tejwani serves, that certainly there is some overlap oftentimes between some of the symptoms of COVID-19 and seasonal allergies. But COVID-19 tends to have a fever and seasonal allergies do not. You also may experience some gastrointestinal upset or diarrhea with COVID-19. You tend to have more muscle or body aches. And the early hallmark sign or symptom of loss of taste or smell is absolutely one that is uncommon with seasonal allergies. So again, these are some of the signs of COVID-19 that may be more indicative versus your seasonal allergy symptoms. Many times, seasonal allergy symptoms do tend to worsen after spending time outdoors. Again, whether it be itchy eyes, postnasal drip, we know that there are some overlap symptoms, those things like cough, shortness of breath, and chest tightness, as I mentioned before, but there are significant differences. So if in doubt, always speak with your physician, have that conversation. But again, I think that what we've heard and seen from our patient community is that there are some unique differences. Now I'm going to turn it back over to Dr. Tejwani, and he's going to share with us a bit more around long-haul consequences of COVID-19.
Thanks, Tonya. Yeah, as mentioned, I'm glad we're speaking about this, and I'm glad it's beginning to get more and more recognition. Again, I think the mortality statistic certainly remains the most important, but there are a number of other consequences, this being one of them, from a COVID infection. So to begin with the definition of long COVID. So long COVID is generally considered to be effects of COVID-19 that persist for more than 4 weeks after you've been diagnosed with the virus. So that might include that you have symptoms in those 4 weeks, and then it continues, and that's what's known as ongoing symptomatic COVID-19, and really consists of symptoms between 4 and 12 weeks. And the other possibility is that you have what's called post-COVID-19 syndrome, which is continued symptoms after 12 weeks. What I really want to contrast this from that some on the webinar may be familiar with is something called post-ICU syndrome, or PICS. So anybody that gets admitted to the intensive care unit, really for any reason, whether it's influenza, a virus, a gastrointestinal bleed, for example, whatever it may be, particularly if you're on a mechanical ventilator, there's a lot of sedation that you receive. You're much less active than usual, even if you're doing physical therapy there. And you're, of course, you're critically ill. That's why you're in the intensive care unit. So those individuals, independent of what the reason that they're there for, when they leave the hospital, whether it's a week or 2 or days later, have shown to have continued weakness, continued kind of brain fog, confusion, issues with cognition. This is different from that. And I think what I really want to draw attention to as far as who gets long COVID are the bottom 2 bullets. So unfortunately, it doesn't really have, it really affects everyone. Young, otherwise healthy people, which I've seen firsthand, and of course has been reported across the literature. And I think one of the challenging and surprising things about it is that how bad that first infection is actually not a good predictor of if somebody develops long COVID. I've had patients, and both at Hopkins and at Cleveland Clinic, there's now a long haul COVID clinic, ones that weren't even in the hospital, let alone not in the intensive care unit, and they still have these persistent symptoms many weeks to months out. I've had a few, this is a minority of patients, where they won't have any symptoms at all initially at the time of their diagnosis. They basically undergo a COVID test for screening or some other logistical reason, and then weeks or months later start to develop the symptoms. And the symptoms, although would be considered quote unquote mild, can actually be quite debilitating. So just reiterating that this could be, on this next slide here, that it could be symptoms that linger, that developed, or it could be symptoms that develop after 4 weeks. And really across multiple studies, the first study listed by Mandel et al. Being conducted in America, and the other study being conducted with some of the initial individuals that experienced the COVID-19 in China. Fatigue, continued shortness of breath, a cough, memory, concentration or sleep issues, and then anxiety or depression. And again, importantly, these are often people that were healthy without significant medical complaints prior to this, and they're essentially left with a chronic illness from the virus. So on the next slide, again, just kind of reiterating that issues like this aren't picked up in what is, again, the most important piece of data, which is the mortality statistic. And I think we still haven't quite borne out what the full burden of this is going to be. There's a great perspective that was put out in the New England Journal earlier, kind of raising the possibility that this could be a slow burn of a national health disaster. They cite 10 to 30% are still experiencing debilitating symptoms months after being infected. That number, compared to some of the other studies that were presented on the previous slide, are actually potentially conservative. The other studies that talked about 40 to 50%. There's probably a little bit of bias based on who actually comes to the visit. Someone that is experiencing symptoms is more likely to come. So I think even if we take a conservative number of 10 to 30%, it's still a huge number of people. And that's really illustrated on the next slide, which if you kind of extrapolate out from the 114 million Americans that have been infected with COVID so far, and we just take about a 10 to 15% range of that, we're talking about 15 million individuals that are experiencing these chronic symptoms that unfortunately are at this point poorly understood. We don't have a clear sense of whether it's a persistent low-level presence of virus, whether it's some kind of immune response that is happening to the virus. And the average age of these individuals is 40, unlike people experiencing severe illness. So there's, of course, effects at the individual level and more broadly at an economic and population level. I think as more and more individuals are getting infected, there's certainly more and more of a recognition of this. And the good news is the NIH and other funding organizations are taking note and are releasing grants specifically to understand this disease and what might be causing it. The next slide just illustrates and is kind of just a brief overview of the effects of COVID-19 acute infection. So certainly in the acute setting, it is a systemic illness. The virus goes everywhere. What is the most pronounced is the shortness of breath or damage to the lungs that can lead to the use of a mechanical ventilator. But we're seeing in not every patient, the minority of patients, potentially damage to the heart, damage to the brain. Not illustrated here is damage to the kidneys as well. There seems to be a direct effect of the virus on some of the cells in the kidney that can lead to the need for dialysis acutely. Most of the patients, if their lungs recover, the kidneys tend to. But outside of the long haul of COVID-19, this just in and of itself has a lot of long-term consequences from just being so ill. Next, I'd like to present just briefly a patient that I met in the middle of last month. I actually met her during a hospitalization. A very pleasant woman, a 53-year-old female that was employed on home health services. And she, presumably due to a visit to someone's house, contracted COVID in January 2021. And I really want to illustrate this point, which is she basically, and this is in the background of a suspected asthma diagnosis, she takes albuterol as needed, but has never had pulmonary function tests. Her chest x-ray is on the top of the slide, and that top portion where you're kind of seeing the black part is essentially normal lung. There's a little bit of haziness at the bases, which is the effect of the virus. And I just want to contrast that to, on the bottom, you see a picture of somebody with very severe COVID. This is somebody that has a breathing tube in place, and their lung is essentially hazy throughout, which is inflammation from the virus. So again, just to emphasize, this woman had a fairly brief hospitalization. She was in the hospital for 2 days, required a very small amount of oxygen per nose, and then received steroids, as is now the standard of care, as well as an antibiotic in case there was a bacterial infection as well. This was in January of this year, and following this, in March of 2021, she unfortunately experienced a blood clot, likely as a consequence of the infection in January. And then she visited our Recover clinic, which is our long-haul COVID clinic or kind of post-discharge COVID clinic. And unfortunately, is now experiencing fatigue, brain fog, in her words, and a headache. And then subsequently underwent a neuropsychological evaluation, which demonstrated severe fatigue and limited attention. She is starting to slowly, with physical therapy and kind of other focuses on her wellness and well-being, improve a little bit, but she's continuing to have challenges. She has been working, but is not able to work as much as she was able to previously, and is finding it a little bit harder to work. And then in August, this is unrelated. Well, it's related to her blood clot as she experienced a gastrointestinal bleed. Fortunately, it's not very severe, and that's when I met her, and we stopped her blood thinner. But I think what this illustrates is there's just this kind of slow brewing infection or immune response. Again, why it's happening or how it's happening is not clear yet. I think as a medical community, we've now achieved the first step of identifying it and better characterizing the prevalence of it. But the two next steps tend to be the more challenging ones, which is why or how is it happening? And importantly, is there anything we can offer these patients? I think at this point, for example, with this woman, we were fairly limited in just really kind of supporting her through it, trying to do physical therapy to regain strength, she did some other mental exercises at home to try to regain some cognitive ability. But it's certainly a challenge to address. And I think understandably, it's when you have so many people that are critically ill at the moment, these folks there's not quite the bandwidth to look into it, to treat it as maybe we could. But I think the encouraging part is we're starting to look into it. So that part is happening. So the next slide, we kind of see that there's really needs to be a multi-pronged approach to this. One and really the most important is primary prevention. And it's the most important, honestly, at an individual level, it's the easiest. Dealing with any of these long-term consequences or an acute illness is really much more complicated and much harder than just preventing it to begin with. I think this, whether we like it or not as a nation or other nations like it or not, it is a global problem. And that's apparent with the variant. Well, it's apparent with the virus to begin with, and now apparent with the variants as well, which is if there's a place, if we get to 80%, 90% vaccination, which would be amazing. If there's another place in the world where it's still brewing, there's that possibility for a mutation to develop that is no longer susceptible or responsive to the vaccine. And then it's this post-infection management, which we discussed as far as whether that's somebody that was very sick or wasn't that sick but developed the long haul of COVID. And next is just a holistic response. And I think this is an important one, particularly in the context of long haul COVID. As doctors, medical providers, you're trained to kind of identify a nail and use a hammer on it. With these long haul COVID, it's a little more vague. It's a little harder to identify. The symptoms aren't as well defined. They don't always have clear abnormalities on a chest X-ray, for example, like you saw with that very severe COVID patient example. So I think that, and it kind of bridges into the next one, is we still will and are continuing to find ways to provide supportive care to these individuals, even if it doesn't always just mean here's, a pill or something like that. There's still other therapies and support that can and should be provided to this for them. On the next slide, and really just to emphasize, the best way to prevent this is to prevent COVID to begin with. And there is now data, this was just published on September 1st by Antonelli et al., that the vaccine not only prevents acute illness, which I think is known, but that 2 doses of the vaccine actually prevent the development of long COVID as well, which is really encouraging. It's fortunate, again, that vaccine has proved to be so effective. And then again, COVID-19 vaccination is recommended for all people ages 12 and older. This question comes up a lot with patients, and it includes if they had a COVID-19 infection. They still should get 2 doses. My only caution to them is that most individuals will experience kind of a harder, myself included, a tougher time with the second dose, but they might experience that with the first dose as opposed to the second. But we don't really know how effective natural immunity is. We do know how effective the vaccine is, that it's not harmful for individuals that have been infected previously, other than those maybe a little bit more side effects with the first dose. So it would still be recommended to enhance their immunity. And
Great.
Tonya, with that, I'll pass it back to you. Thank you.
Yeah, so let's now go back to our final poll question. Do you or someone you love suffer from long COVID? And let me get here, sorry, to that poll and launch it for you to cast your result. I know I have had so many conversations with patients that continue to experience long haul COVID symptoms. So yes, no, maybe, or I don't think so. Go ahead and log in your response. Do you or someone you know and love suffer from COVID-19 long haul? So we'll go ahead and have you log your responses. And for some reason, it is not logging responses on my end. So we'll give it just another moment, see if those come up. Go ahead and close the poll because I definitely want to get to some of these wonderful questions. Yeah, unfortunately, for some reason, that poll did not work. So I know that in our experience, that number of 10 to 30% actually has been the reported incidence of long haul COVID in our community. That we're seeing that very frequently. And as you say, it really is otherwise healthy individuals, not necessarily just the aged population or those living with comorbid conditions, or even those that had severe COVID. Certainly those that had COVID and ended up being ventilated are having long-term implications from that, but definitely we're seeing the prevalence much broader than even just that community. So now we want to hear from you. Please go ahead, log in your questions. We're going to get to as many of those as possible. I've got a number of them in the queue, and so we will hop right to it, Dr. Tejwani. The first question is this: if I had a reaction with the first dose, should I pre-medicate and take with Benadryl and take the second dose of the vaccine?
Yeah, that's a good question. It's certainly a tough situation. I think if it is a milder reaction, meaning like a skin reaction, it would be probably okay to get the second dose. I think it's a little, if the first dose or first reaction is like a true anaphylactic where your throat tightened up, chest tightened up, unfortunately I'm presuming this is Pfizer or Moderna, should not give the second dose. Assuming it was just a skin reaction, I actually would not suggest pre-medicating, but I would suggest bringing the Benadryl to the appointment and telling the individuals there regarding your reaction to the first dose, whatever it was. Like, again, working with the presumption it's a skin infection or skin reaction, excuse me. Just briefly, the reason I would recommend that is just that if you are to have a more severe reaction this time around, whether skin or otherwise, we wouldn't want to blunt the response of that at all. So assuming they felt comfortable giving it to you, you would receive it, you would get monitored for some period of time, as long as there was no airway compromise, and let's say the reaction was a skin reaction, you could then take the Benadryl. It's not quite as good as preventing it, but it's safer than potentially blunting and hiding a response early or a reaction early.
Right. Thank you for that clarification. And again, if you've had a severe allergic reaction, then it is not recommended that you take the second dose. If it was a mild reaction, then again, that should be a conversation that you have with your physician around bringing the Benadryl to that appointment prior to. Now, if the next question comes from William, if someone received 2 Moderna dosage of the vaccine, can they get the Pfizer booster, or do they need to wait for the Moderna booster?
Yeah, that's a great question. I'm in that camp. I've received 2 Moderna and would be at about the time mark as well. In theory, you should be okay to get the Pfizer one because those two are the most similar. They're mRNA, and actually, so far the Moderna, although the Pfizer was a little more effective earlier, the Moderna seems to be a little bit more effective against the Delta variant. But anyway, kind of suggestion there would be if you're immunocompromised, I think I would go ahead and proceed. If you're not immunocompromised and maybe just getting a little understandably nervous with reports of waning immunity and higher transmission, I might just wait a little bit to see, because I think Moderna should be out soon with their booster. But I think if you're immunocompromised, it would not wait, and it should be safe no matter what, because they're both the same molecule effectively.
Yeah. Okay. Thank you for that. Now, the next question is a great one from Mark, who says, do you recommend staggering your flu vaccine with the booster for the COVID vaccine?
Yeah, that's a really good question. Moderna just released today that they're going to release a combination vaccine, a flu and a COVID vaccine. So I presume the answer is you probably don't need to. I would have thought before that to stagger them by 2 weeks. If you've received the flu vaccine before and you are someone that has a reaction beyond just arm soreness, I would still suggest staggering it despite the combination that is offered. But if you've received the flu vaccine previously and generally done well, then I think it would be safe. This comes up when I see hospitalized COVID patients that are going home and ask about the vaccine. It would be their first doses. I'm recommending, and it's honestly not evidence-based, it's just based on what we understand about the biology of the immune system, recommending they wait 2 to 4 weeks. So if you either had a really bad reaction to the flu vaccine or the second dose of, be it the Moderna or Pfizer vaccine, would wait 2 weeks, should be a safe bet.
Okay. The next question comes from Leanne, and it is specifically about the FDA-approved Pfizer vaccine. Comirnaty, I believe, is the way that you're going to pronounce that. Is that actually available on the market yet? Is it the same one that was used under the emergency use authorization?
Oh, yes, that's a good question. It's the same one. It just basically, once it's FDA approved, they're now releasing it under a brand name, but it's the exact same. It's similar to like Advair and fluticasone salmeterol. It's the same medication underlying.
And so the ingredient of the vaccine is the same as the one that was under emergency use authorization. And if you want to get the list of ingredients, then that's certainly available at those websites. Okay. Let's see. Children are returning in-person learning at school this year. What is your recommendation on how frequent COVID testing should be done in elementary school students who are not yet eligible for the vaccine?
Yeah, that's a good and a tough question. I think basically you have to base it off community transmission. I really don't have a great answer. I mean, the right answer technically would be every day, because if you have a single asymptomatic carrier, then the whole class is infected, and it's unfortunately as simple as that. And it's impossible to track what somebody is doing, what every child is doing outside of the school hours to know if they were exposed or not. So I recognize that's not feasible or logistically possible, or probably even cost effective. So I unfortunately don't have a good solution there. I mean, as frequent as possible from a cost and logistical perspective.
Yeah, and again, would you be recommending to your patient community to get tested only in the presence of symptoms?
Yeah, unfortunately not. I mean, I think that's what we're seeing, is that now even if you're vaccinated, that you could still carry it and transmit. So no, I think reasons to get tested it really depends on who you're exposed to. So if you're working at home and let's say you're living with, just a spouse, for example, or your children are still, I mean, I think most kids are going back to school, but if there's a possibility that you've had community exposure, symptoms are not a reliable way to get to count on the diagnosis. That doesn't mean we all need to do surveillance testing, because that's also not a very reasonable thing, but I generally have a very low threshold to get tested. Or if you're what I advise when patients, they're living with an older family member or someone that they're maybe at a high risk exposure up to get tested a little more often.
Right. Now, our next question from Claudia is a very good one in regard to, are you seeing more mild long haul symptoms like the loss of taste or smell?
I personally am not. I should say I don't serve in these long haul clinics often. I'm there like intermittently. Most of my time exposed to COVID is in the intensive care unit. So I personally haven't. That's not to say it's not. I believe it has been reported across those two studies that I discussed. And I would just say my lack of personal exposure is likely because I'm just not there as often as I am in other places.
Yeah.
It's a good question.
So the next question comes from Dawn, who says that her friends have actually told her that if you had COVID, you really don't need the vaccine. Is that true? Is there any data that actually supports some of the concerns around fertility in young women who get the vaccine?
Yeah, those are great questions. I think the fertility one I think is fairly straightforward, which there isn't any data to support that. And I mean, at the expense of maybe getting a little more personal than necessary on this call, my wife received it probably about 2 months before we conceived. And then as far as the natural immunity part, I think that it's a good question because there are some infections where you get it once and you're done. Unfortunately, meaning you essentially have lifelong immunity and you're set. Unfortunately, that's not the case with COVID. Even before the vaccine was developed, and Tonya, remember some of the early webinars we were doing in the summer of 2020, we were talking about reinfections. So it's the natural immunity is certainly not 100%. And we have even less data on how long that lasts. I mean, there's some question, obviously, with this third booster, like is 6 months the right number, is 7 months the right number, is 8 months? And I think that's a real question. But natural immunity, not only does it not truly protect you forever, it also doesn't last forever. So even if you're good for like a month or two, you still might get reinfected shortly thereafter.
Right. Now, in the context of long haul, does that imply that this could last for the rest of a person's life, Anne asked?
Yeah, that's a good question. The short answer is we don't know. We don't know only because we don't have enough data yet. There are people that are recovering, but I mean, there are many people that haven't yet. So we don't know. We don't know what the duration is going to be. And I think as this funding gets released to understand more about what's causing it, we might understand that better, because the way you would, if it's like a persistent low level of a virus, there's certain ways to treat that with virus suppressing medicine. If it's an immune response where it's overactive, there are ways to treat that with either steroids or more targeted immune suppression. So it's a good question and a concern, and an understandable concern for all of us, but we don't have the answer to that yet.
Absolutely. And so time will tell. I mean, that is what, again, we continue to all be in the midst of the pandemic and in the midst of the journey together. As we said at the outset, we never would have dreamed that we would be here on our 30th webinar around this topic 18 months down the road. So time will tell. Stay tuned. We'll continue to bring you the latest data. Well, again, I want to thank everyone for listening on the line today. Definitely want to thank Dr. Tejwani for his expertise and perspective. As you know, Allergy and Asthma Network is and will remain committed to bringing you the information that you truly need during this time. Our next webinar is actually scheduled for September 16th, and we'll share information about Allergy and Asthma Network and how we can continue to support you and how you can help us and get involved in more network activities. Also, please plan to join us on September 23rd for Asthma in the Yellow Zone, where Dr. Lynn Becarier will talk with us about managing asthma flares and look at appropriate medications for doing so. Once again, thank you for joining us. I'm Tonya Winders on behalf of the staff at Allergy and Asthma Network, where we want to continue to bring you the latest on asthma, allergies, and COVID, so we can work to stay well during the pandemic and breathe better together. Have a wonderful day.